Hi everyone, I am Chirag Thakkar, commissioning editor at Roli Books, and you're watching this video in collaboration between Roli Pulse, brought to you by Roli Books and MoJo Story. If you haven't already, please select the bell icon and subscribe to Roli Pulse as well as MoJo Story on YouTube and follow our individual social media handles. With the global toll of COVID-19 cases crossing 6 million, over 2 lakh cases detected, diagnosed, and reported in India alone, making India the carrier of the seventh largest number of cases, the race to finding a vaccine and, in the interim, a solid, dependable treatment or cure has become more desperate than ever. As attempts to use remdesivir for COVID treatment in India are underway, the question everyone's asking is whether a cure for coronavirus is in sight. Discussing this and the state of India's healthcare system are Dr. Ambarish Satwik of the Ganga Hospital in Delhi. We have Hari Bhartia, founder and co-chairman of the Jubilant Bhartia Group, a conglomerate into pharmaceuticals, oil, life sciences, among others. We are joined by Dr. Naresh Trehan, the founder and managing director of Medanta. Ambarish, Hari, and Naresh are going to be in conversation with the award-winning journalist Barkha Dutt. So welcome to Roli Pulse and MoJo Story. Barkha, why don't you get us started with this discussion?
Thank you very much, Chirag. And as Chirag said, welcome to this collaboration between Roli and MoJo Story. Many of you would know that this is for our team the 80th day on the ground reporting this pandemic, the lockdown, and its consequences. And today, on the day of the recording, we're in fact in Mumbai, where the cyclone is only compounding the challenges of this pandemic. And really, we cannot discuss the overall situation without discussing affiliated challenges, whether it's economic hardship or whether it's natural calamities. And we have to keep all of that in mind when we think of a holistic approach and the best possible way forward for a country like India. Chirag has already introduced our panelists today, so without much ado, will get straight into the conversation. Let me start with you, Dr. Trehan, if I may. We've had a few moments of optimism, and then that optimism has come crashing down. So, for example, hydroxychloroquine, which in India remains something that is used by doctors both therapeutically and as a preventive by health workers, Lancet didn't agree. The World Health Organization didn't agree. Now we are pinning our hopes on remdesivir, and I want a sense from you on how optimistic we should be about the use of this drug, which I know Jubilant has also licensed to manufacture in India. But what is the basis of our optimism, and how far can we stretch this optimism at this point?
The principles of one treatment, the other is cure. There are two separate issues here. So one, when we look at it, the mechanism in which the virus attacks the body, it attaches itself. You see all those spikes in the pictures, that's known as the S protein spike. It goes and couples itself with what we call ACE2 receptor. ACE2 receptors are in the body. They regulate the blood pressure, the kidney system and all that. So they are essential to the body. There is a port in there where S spike goes and attaches itself. With that, it starts multiplying. And at some point, it kind of explodes through the body. So the mode of mechanism is first, it's supposed to go into the upper respiratory tract, where it multiplies and then gradually goes into the lower respiratory tract, into the lungs. So first line of defense could be, if you can block that receptor, the ACE2 receptor from coupling with the virus, then you'd be able to contain the multiplication of the virus and hence be able to reduce the effect on the body and give the body a chance with its immune system to actually tackle it. That's the first one. And that's where we talk about, and this was an observation, but it has now been published in the largest study, that statins, which we use for cardiac disease, for lowering of cholesterol and all, they actually block that receptor. So we have found this was an observational study of our 14 Italians who were admitted to our hospital first, the very first group that came to India, that 11 of them were on statins. And they seem to have recovered much faster than the other three. The other two took a little longer and one didn't make it. That was a 78-year-old lady with multiple comorbidities and her heart was already 25%. So she had been suffered a heart transplant. So anyway, from that, in the US, they've just published a study where they have said over 30,000 patient observation that it seems that statins seem to help them. So that's not a really controlled trial, but these are observational. The second mode of defense is where remdesivir comes in. These are antiviral, or they actually reduce the viral load in the body. Then again gives the body a chance to fight with its own immune system. So remdesivir was actually invented or worked out in the time of the Ebola. And these drugs, there are many of these drugs which were on the shelf. And there are some other antivirals which we use on a regular basis. So those have been, out of this lot, the first one of the block is remdesivir, which was repurposed by Gilead. So Gilead has actually gone much further than most other projects. Some of them are being done in India, at Medanta also, but we are way behind. It will be 3 to 6 months before we can come up with the final answer. We are doing it on a drug known as TCZ. So anyway, remdesivir has reached a stage where there was the initial trial done by National Institute of Allergy and Infection. They had done that showed two parts of remdesivir. One was that it shortened the recovery period. That means it had some antiviral activity. And the other thing it showed was instead of giving 10 days of remdesivir, you could do with 5. The results were okay. But what it didn't show conclusively, but it did indicate that in the study, 10 patients died who were not on remdesivir and only 8 died. So there was a divergence of 2. But that does not become statistically significant because of the size of the study. So the second study, which Mr. Bhartia is aware of, has just actually been concluded. The exact results may or may not be available yet, but the point is that that's the release by the company says that yes, it may be actually as effective as they thought in the first trial. So that's where we are at with antivirals, and there are many candidates that are in the run. So hopefully we'll get more, and maybe synergistically some can be used. But the ultimate cure, as you know, is it's not cure, but it immunizes you, the vaccine.
Yeah. So now the vaccine, no matter what we do, and even if we look at people who are working on it in India, like Adar Poonawalla, you are looking at least till the end of the year before you can realistically talk about a vaccine. Hari Bhartia, when you take a decision to actually, in a sense, put your optimism, put your faith behind remdesivir, to some extent, like much of the world, you are still groping in a space of uncertainty. Can't even call it a calculated risk. You have prima facie information. You still have trials to go through. You still have people who need to be part of these trials. So what makes somebody like you partner with Gilead to take this ahead? Because we've had so many false starts and so many shifts in science. Something small like a mask. If you remember, World Health Organization started by saying you don't need to wear a mask. Now when we go out, we all wear masks. So I want to understand from you the reason that you have decided to professional and from a business point of view back to the science.
Barkha, firstly, as you know, we do make drugs, we do make APIs, we do make sterile products. And Gilead is also our partner in US in different products that we make for them. We felt that remdesivir was a lead antiviral. Even 2 months back, if you really look at it, the world was struggling to find a way to control this virus. And even today, if you compare all antivirals, remdesivir seems to be giving the best result from whatever clinical trial data that I have seen. And even if you see it lately, the results that came out 2 days back, from a standard of care, it is significantly better results, even on a 5-day dose that you saw, that a 5-day dose is equal or better than a 10-day dose. Now, the reason why we went into it, we felt we have all the knowledge and expertise to produce this drug very fast. So in fact, we licensed it about 15 days back, and we are hoping that we should be able to bring out this drug in July sometime. Late July, we are hoping to bring out this drug. And there are 4 companies which have been licensed. Maybe more get licensed. So the good part is the availability of drug in India will be, the idea was not to make profit, but the idea, initially is really to see that how could we make these drugs available in India cheaply. Because I don't think we could import this drug from US, because US has a short supply of these drugs. They are not able to give access. Dr. Trehan knows, even for clinical trials, we could not access these drugs except by only participating in this solidarity trial, which India is now participating, and I'm sure Medanta may be one of the centers where this is being tried. So the whole idea is, we are all struggling. We are all trying to find a solution. If we can at Jubilant contribute in some manner, I think that was the idea.
Okay. Hari, at the moment, this drug is only allowed for emergency use in India. That is the decision of the ICMR. It is an emergency use drug, and we're very much in the space of experimental therapy. Everything that we're doing right now is experimental. We are to that extent groping in the dark. So what do you feel about that?
No, I feel, if you really see, in a week's time, government has given approval for emergency use. So somebody like Dr. Trehan can decide and use it on patients. So to that extent, the drug is available to all the hospitals, and it's an injectable. So chances are it will get used in most of the time, 90% of the time, it will get used in the hospitals only. So the reason why they have given only emergency use, because FDA has also still till date not allowed, not given a full approval. And with the latest clinical trial data, I am hoping in this month we will see an FDA approval. Now, if that happens, chances are the Indian Drug Authority can also give an approval. But for them to give even an emergency use approval so fast, I think unbelievable. Really, they have moved fast, and to be fair to them, they have been pushing to get this drug into India. And they have been talking to us, and we have been in constant touch. So really, the idea is to get the drug available, and even with emergency use label, doctors can access these drugs very easily.
Okay. Dr. Ambarish Satwik, on the ground at a hospital like Ganga, what do you find? Because, most doctors I'm speaking to, and I've been inside now dozens of COVID hospitals, there is a trial and error approach. And the feedback that I get from doctors is no one size fits all. So some doctors believe in the HCQ, they're still doing the azithromycin plus the hydroxychloroquine. Some are, wanting to do blood thinners. Some would want a remdesivir kind of approach. What are you finding on the ground, Ambarish?
Yeah. So allow me to say that, just to add to what Dr. Trehan and Mr. Bhartia said, that what's happened with remdesivir is that, first of all, the FDA gave an emergency use authorization. This was followed by the drug controller and a committee in India giving emergency use approval, because otherwise any such drug will have to undergo local phase 3 trials before it can be tested. Now, I've gone through the NEJM paper that was published on remdesivir. It's about 1,000 people, and there's one particular subset of patients who seem to be benefiting in particular. These are patients who require oxygen but don't require high flow oxygen or ventilatory support. Okay, in patients who don't require oxygen, remdesivir doesn't make a difference. In patients who require high flow oxygen or non-invasive ventilation or ventilatory support, it makes no difference, possibly because this drug is blocking replication of virus. If you give it too late in the course of the disease, it's not good enough. It's not going to make any difference. But patients who have just started requiring oxygen, it shows an improvement in recovery, though it does not offer any mortality benefit. So I have been speaking to intensivists. I can't say that all over the world we are breathlessly excited about this, about remdesivir, but definitely it's a proof of concept study. And you have something that is able to stop the virus in its tracks, at least to a limited extent. Now, about hydroxychloroquine, the singular difference in the Indian approach to hydroxychloroquine, and that is what the ICMR has just published, is that we've been extensively using this drug as a prophylactic. Most of the studies, even the Lancet trial, which has now come under question. In fact, just today, I think the Lancet has issued, a little bit of an editorial note saying that there have been serious questions raised about this trial, and we're looking into this because the quality of data isn't particularly good. So the Indian experience with hydroxychloroquine is that it's been given as a prophylactic. All of us, all healthcare workers have been taking it. It's been given to police officers. And initially, to begin with, there was a lot of anecdotal evidence that people who have been on hydroxychloroquine as a prophylactic, even if they have contracted the disease, it hasn't led to the severe complications of the disease. And now the ICMR study seems to give it almost an 80% benefit as a prophylactic. Though as a therapeutic agent, there isn't any great evidence that it's making a difference. But to now answer your question about how COVID is to be actually treated in hospitals and what are we looking at, there are 2 points I'd like to make here. First of all, if you observe, there's something very strange happening on the Indian subcontinent, Pakistan, India, even in the Far East. If you see that the number of cases are going up, and they're going up quite rapidly, but the daily fatality rate, the number of deaths is at a plateau, okay? Even if you say that the testing is increasing exponentially, but you cannot deny that the number of infections, the numbers are increasing rapidly, and the case fatality rate is actually falling. So if you were to plot the number of infections against the number of deaths, though you're not seeing the daily number of deaths at a plateau, but as a fatality rate, you'll see a declining trend. Well, that seems to be suggesting, and the only inference you can draw from this is that the virus seems to be losing some of its virulence, okay? It's becoming less virulent, less deadly perhaps, and this is also exhibited by the sheer great number of asymptomatic cases that we see. Nowhere in the world did you encounter this, these many asymptomatic cases. In fact, when it started out, when we were getting reports from Wuhan, they said, if it's just 1 to 5% or 7% asymptomatic cases, then you started getting reports from Europe saying it's about 30% asymptomatic, perhaps 40%. And as the virus has traveled through the world, as it has moved through bodies, perhaps there seems to be an evolutionary change in the virus, which is making it less virulent, which is why you're seeing a great rise in the number of cases, but a declining trend in the case fatality ratio. And there's a very interesting theory that could be put forth, which is the theory of evolutionary biology. I'm happy to talk about it if you have the time, but we can do it.
We'll come back to that. And in fact, I remember I was interviewing Siddharth Mukherjee, and he made this point about India being this great outlier in terms of the fatality. So what I'm hearing Ambarish saying, and let me take that back to Hari and Naresh, is that when you look at the data in India, and even if you allow for the fact that not all the data may be accurate, there could be underreporting. We've seen controversies of mismatching between government released data and hospital released data on fatalities. So even if you allow for some gaps there, the fatalities are not what we are seeing globally. So I think that's quite clear thus far, and may it remain that way, even though the virus remains highly contagious and therefore its spread is quite fast, but its lethality, it's in terms of it being lethal, mercifully, we're not seeing that fatality rate. Hari, do you want to just add, both you and Naresh, to what we've heard Ambarish say, and then we'll step back and do a big picture look at the hospitals? Hari?
I fully agree with what Ambarish said. Whatever I have learned, we had an incidence in one of our facilities, and almost 1,500 people were tested, and almost 90% were asymptomatic. And so that's a good sign. That's a good sign. People who were tested positive, of that 90% were asymptomatic. So to what Ambarish said, the fatality rate is low, because you may blame the government for not testing enough or whatever. Maybe the actual numbers of people who have been infected is high, but the fatality rate is, I would say, plus minus 10% is an accurate number. That cannot be, I think that can be measured very clearly. So with that in mind, the fatality rate is in control. Now, is the virus mutating into a more weaker form? Could be true. I've read some of those papers which Ambarish mentioned, and normally it takes a year for it to mutate into a weaker form. That's what I learned in some of the papers. But evidently, if that is taking place, then it's good news. It's good news, because then even getting a vaccine will be faster, because what we need is a weaker form of the virus, or what they call attenuation at a weaker level, that which can then be used as an antibody in the virus in the future. So I agree that this is a trend I am also seeing, and seeing it as a good news. But is the contagion reducing? I don't know. That's something I still worry about. And but then the challenge is, people are saying, should we open up or not open up? But I think on that debate of life and livelihood, my bet is that now, after these 2 months of lockdown, the normalcy have to return, and each individual needs to take protection. Be careful. We can't be less careful. We continue to be careful, but we have to go about doing our normal work also.
Dr. Trehan, let me add a question here. You know, I'm standing in Mumbai, and after traveling about 16,000 kilometers through 12 states, the one thing I've understood is that a lot of Western ideas of how to respond to this virus cannot work in India. So let me give you one example. This thing called social distancing. When you have migrant workers, hundreds of them crammed onto the back of a truck or into a train, social distancing means nothing. When you have 92 million Indian households living in one room, and I've been into areas like Dharavi, for example, where there are 8,000 bathrooms for 8 lakh people, social distancing means nothing. When you go into public hospitals in casualty wards where COVID patients and non-COVID patients are sitting together on the floor because there are no beds, social distancing means nothing. My question is, do we not need to know our realities and have a very India-specific understanding of what we can do and what we cannot do?
So, Barkha, there are several factors at play in India. First of all, the rate of death is getting lower and lower around the world because our understanding of the pathophysiology of the disease is better today than it was before. Before, we always thought that the virus actually consumes the lung tissue, and that's why the oxygenation drops, and that's why people die of asphyxiation. Then the Italians, against the advice of WHO, did an autopsy on 50 deaths, and then discovered that the pathophysiology was that because of the cytokine storm, in the response of the body to a major attack by the virus, that it created enough inflammation in the endothelium of the arteries, and especially the smaller arteries, where blood clotted. So these arterioles that go to the lung to exchange the oxygen, they got clotted. And that's why the death was happening, and we could not improve the oxygenation in spite of every machine we used. So that's when we started adding heparin to it. And then the point being that if there is inflammation, then can we stop it with steroids? So a lot of tweaking has been done in the treatment, which has helped to reduce the death rate, including the fact that we have a demographic advantage of 35 or 50% of our population is below 50 years of age. 35 years of age. Sorry, I got the figures wrong. But anyway, now the point is, coupled with BCG, coupled with young age, coupled with our labor force, which you are talking about, the ones that are living in jhuggi-jhopis are actually possibly much more immune than the Western population because they live in such contaminated surroundings, and that they are physical labor, that we know muscle gives you immunity. So as the stronger your immunity, the less the virus will be able to overcome you. So these factors will all play in. Now, the point is, when you say Dharavi, when you say that our clusters are so dense, that yes, it will spread through, and we don't know how many millions have gotten it. We don't know that. And it's very possible that a huge number of them are asymptomatic and they're actually recovering. And all the people you have seen in the back of the truck, if you tested them, possibly a very large number will come out to be positive who are in the recovery phase. Or they were lying for 60 days in small areas in contaminated surroundings. So when we do a survey of the community, when we are able to do rapid testing to see where that would be the value of rapid testing. That will tell you how many people have developed antibodies, which will tell us how widespread the problem has been, and slowly herd immunity is taking place. But the point is, it has to be 60-70% of the population to be effective, to what we call the natural shield. That will happen maybe a year or two from now. But it would be worthwhile today to do an actual testing in all these areas, which is very easy to do with rapid testing, to really get an idea of what happened in the last 60 days, what's happening today, and how do we plan the future. That's when the truth will come out. But I think, given with all the Golgappas in the chart and all that we eat, probably has given us much better immunity along with BCG, which makes it, in a way, maybe that's the blessings of all these things that we've been doing for all these years. Those 8,000 toilets that you were talking about for 8 lakh people, they must be giving a lot of cross immunity, I'm sure.
So Ambarish, you call it evolutionary biology. Naresh uses the metaphor of Golgappas. I say it's the tap water versus filter water sort of metaphor. It's the reason that when, you have people who come from America, they eat off the streets, they have belly, nothing happens to us because we're more accustomed to it. What is actually going on? You have a Kiran Shaw who says we've had exposure to zoonotic viruses. We don't actually fully understand why many of us may be infected by the time this is over, but hopefully not many of us will die, especially when you compare it. And this is what worries me. And this is what makes me wonder whether we are too obsessed with coronavirus, especially when we compare it to other fatalities. We have forgotten that 1,300 Indians die from tuberculosis every day. We have forgotten that 1,300 Indians die from cancer every day. We have forgotten that people are dying because they can't get dialysis anymore at private centers without a corona test, which there aren't enough tests to go around to get that dialysis done. So are we being too obsessed? Let me just, address the elephant in the room. Are we overreacting in a disproportionate way now that we know the fatalities to coronavirus?
So I don't believe we are over-responding. I think the trouble with pandemics is that and particularly in epidemics on the Indian subcontinent, is that the denominator is very large. Okay, so even if you take a very small number of patients who will land up in ICUs. So for instance, Delhi NCR, the combined population is about 4.5 crores. So even about 2% of these, 3% of these require intensive care to be have the ICU beds. And if they fall sick at the same time, so if it's peaking all together, then you're practically at breaking point. Practically every kind of, wherever the virus has traveled, you've seen, even in first world countries, both public health infrastructure and private health infrastructure has been severely inundated and snowed under. So I don't think we're obsessing about this. About your question, which is asking why this is happening in the manner and why is it playing out in this manner in India, it's actually very enigmatic, because if you see, and Dr. Trehan mentioned herd immunity, in London, for instance, the epidemic is almost on its way out. It's almost been snuffed out in the sense that just a handful of cases are being reported every day. They did a serological survey in London, and a lot of the experts seem to believe that only about 15 to 20% of these patients have developed antibodies. Now, this means that their bodies have evinced antibodies to the virus. This does not mean that there wasn't another kind of resistance mounted by the individual against the virus. It just means that the antibody resistance, that form of immunity wasn't there. So clearly, there are other forms of resistance that the human body is capable of mounting against the virus, not just the antibody form, which is having this effect. So if you're able to not just have the downturn on the peak of the epidemic, but almost see the epidemic being snuffed out with about 20% of the population developing antibodies, that clearly means that herd immunity is a very complicated threshold. and it might be easier to achieve than looking at 70% of the population developing antibodies. Look at the Far East, for instance, Japan. Japan has the lowest per capita testing anywhere in the world. You know, it tested about 2,000 or 2,500 individuals per million. Compare that with 900,000 tests per million in South Korea, or about 65,000 tests per million in the UK, or in Delhi, 11,000 tests per million. But they've had just about roughly 850 deaths. They have about 16,000 cases in all. So this doesn't mean they've been reckless. They've just looked at this epidemic in a completely different manner. They've been tracking the serious cases, quarantining and isolating and treating the symptomatic cases, not worrying so much about the asymptomatic cases. You know, if you ask me, I think this principle we have of treating every COVID case as problematic. You know, you go and paste posters saying that there's a COVID case inside in this household. You know, this is the worst form of stigma. Nowhere in the world, you name one country where they do this. Anywhere, they don't do this. I think you fundamentally have to start treating asymptomatic COVID cases as being qualitatively different from symptomatic cases. Perhaps it's a different strain of the virus. And in fact, if you ask me, the asymptomatic COVID cases are going to be our saviors.
I think that's a very interesting point. But in the last 10 minutes, I want to take a look at the whole private-public fault line in our health system. And I'll start with you, Dr. Trehan. Both in Delhi and Mumbai, and in Mumbai in particular, where private hospitals are now requisitioned by the government, the load and the burden is still on the public hospitals. You know, even today I have done a round of the public hospitals, and this is not a judgment on the doctors at all, but there are COVID patients sitting on cardboard strips in the casualty ward because there is not just a shortage of beds, there is a shortage of doctors. Many of the doctors at these hospitals are testing positive, and many doctors in private hospitals are not showing up for work. This is now established in Bombay. I don't know if it's quite the same in Delhi, Dr. Trehan. We are looking here at a very big moral conflict when it comes to the private sector response. How do you see this both in Delhi and Mumbai and elsewhere in the country?
So fortunately in Delhi, we have not seen any real reaction to doctors not wanting to take care of them. They are scared, for sure. You reassure them with the proper, appropriate protection with PPEs and all that. They are still a little, but they don't run away, or they are still there on the ground treating patients the way they are, in spite of the fact that in the early stages when PPEs were not available here, or proper ones were not available, that there were many infections to the healthcare workers, which has, I think, almost come down hugely. Okay. But under the Pandemic Act, the government has the powers to actually force doctors to be on their jobs unless they are sick themselves. Otherwise, their license can be suspended. The government, if it finds that the private doctors or whoever is, or any hospital who is not following the rules established by the authorities, should be punished immediately. The question of tolerating this kind of thing from doctors or from hospitals for whether they are worried about their money, so the government has to be fair. The government has to make sure that the hospitals get enough compensation to survive. Nobody has enough money to do treatment free. So that is a given, that the government has to have a realistic, well-established system of repayment, whether it's the private patient who can pay himself or whether it is the poor man who can't pay at all. So this makes, once it's established, and if the hospitals and the doctors do not behave themselves, then most certainly in this time where the public needs you so badly, that you should be punished, no question in my mind. So that's why there is no excuse. I don't know what has happened, but I don't hear of it in Delhi that this has happened. But Mumbai is a worse story because of the fact that it has run through almost like New York. And there is a huge burden, no question. But I didn't know about the other part of it, that the people may be reluctant to take care. Yes, I heard in the beginning on one of the shows that the private hospitals were reluctant to participate. But when the need is there, you have the powers, the government has the power to requisition. Absolutely.
So are you saying, let me ask something controversial, Dr. Trehan. Are you saying a doctor who doesn't show up to work today should lose her or his license? If, let's say I'm a private doctor, if I'm a doctor and I say I'm not coming to work, should I lose my license?
If you are doing it because you don't want to come to work to take care of COVID patients, yes, you should be suspended first, and then stricter action taken. Most definitely, because this is our calling. Why did you become doctors? Just to have a cushy life or just to be able to make money? No. You became doctors because you want to practice your profession. It's your Hippocratic oath. You will not deny medicine to anybody who needs it. Like I said, there may be some concerns about hospitals losing money and all that. That the government should take care of, undoubtedly, because that is the backbone of this whole fight. So I think from that point of view, the government has its own responsibility, and doctors and private hospitals have their own responsibility to participate fully in this whole war.
Bhartia, we've also seen this fight engulf other aspects of the private sector. It started with how much should a test cost. First, the Supreme Court wanted it free, then there was a capping. Now you have in Mumbai, for example, fees cap. But when you talk to patients, they say that there might be a 9,000 rupee cap, but that's not how it works. That 9,000 rupees is just for the bed. It's not for the drugs. It's not for other things. So there's a lot of tussle going on. For example, there's now a petition in the court over whether N95 masks should be of standard quality and cost the same everywhere. N95 masks, for example, vary in quality and cost different things depending on who you procure them from. So this private-public collision that we've seen in this pandemic, how do you read it?
So Barkha, initially, if you look at PPE or masks, because there was sudden huge demand and there was a short supply. So some people may have increased the prices. But I think if you have seen lately, the supply part has been increased tremendously, and the private sector has come around by manufacturing. So there's a new industry of PPEs which has come up. All the garment manufacturers turned their factories into PPE manufacturing. Masks are being manufactured. So today it's easily available and prices have come down. So there may be some stray incidences of people overcharging, but that should not be the norm. But I think today what my interaction with my industry colleagues is, as far as COVID related issues are concerned, I make a product like sanitizer. We had an alcohol manufacturing facility, which we quickly in 15 days converted into a sanitizer manufacturing facility. And we gave access to that to all hospitals, all local authorities. So to that extent, the effort from the private sector has been that it should be available at a very, very reasonable price, especially things which are related to COVID. On the hospital front, I will not be able to comment. We have Ambarish and Dr. Trehan. They can comment on that. But I find even when remdesivir will get launched, or you see availability of hydroxychloroquine, these are very cheap drugs. They are not expensive at all. And I think to that extent, you must congratulate the Indian pharmaceutical industry that our prices here in India are the lowest in the world. And very good quality, and of very good quality, I must say.
Okay, Dr. Trehan, briefly, and then I'll give the last word to Ambarish. You wanted to come in on that?
So what I wanted to say was, like you talk about private and this conflict going on, it's not true. Like what we did in Gurugram, 3 hospitals who are competitors, Medanta, Artemis, and Fortis. We got together and we have created a COVID facility for public use in Manesar. We are staffing it free. We are giving all our supplies that we can give free. And there's a group of volunteers known as Gurugram COVID volunteers who are giving us some supplies and some gap funding. And this is a huge public project that we have created in the spirit of trying to help supplement the government's facilities, because the government has had X number of beds and we added another 150 beds to it. So there is not a real conflict going on, but there are people who, like Hari said, if somebody is an outlier who's doing bad things, then they must be brought to discipline or fined or whatever is the appropriate thing. But it should not taint, because I think most hospitals and doctors having overcome the initial fear and feeling secure with the PPEs and all that, are now functioning quite well.
Okay, Ambarish, Gangaram has a different model. It's a trust-run hospital, so it's strictly neither public nor private. It's kind of blend of both. Do you like Dr. Trehan and Hari Bhartia believe that this is a fault line that I'm overstating? Maybe I'm in Mumbai, and here really there's a crunch of doctors and even ward boys. Like, I'll give you a small example. I met a woman today who goes in and looks after her mother who's COVID positive in a public hospital because there's no ward boy. And actually, this is an isolation illness in the West. She should not be allowed to meet her mother. But she goes in every day because there's no ward boys. We run short of staff here in Mumbai in public hospitals.
Absolutely. I'll agree with you. I think you require a lot of dedicated manpower to save lives, particularly in an illness like this. For example, in every patient who's in the ICU, you need awake proning. You need about 3 people to turn this patient in a particular position so that they can breathe easier. You require manpower. It's not going to happen just with doctors and nurses. But to answer your question, I think the important thing is that there has to be careful consideration and deliberation and consultation with private hospitals when you take decisions like this. To give you an example, even if you were to start OPDs in a private hospital, you need to start retrofitting the air conditioning, making sure there is air handling units. There are at least about 12 air circulations in an hour so that other patients are not cross-infected. So this requires careful consideration. This requires time. This requires, some amount of braking, shafting, air conditioning, all of that. So you just can't issue a fatwa saying, from tomorrow you should all start treating COVID. This has to be done in a planned manner. So which is why I said, 60 days or 70 days of lockdown, we were very good with keeping the numbers low in the initial phase. But in terms of ramping up capacity, both private and public, in consultations with private players, telling them what to expect, how to go about it, how to make their hospital COVID compliant, there was no movement there. You just can't suddenly announce these decisions. Secondly, I think capping for treating COVID patients doesn't make sense. If you do decide to cap, the deficit should be paid by the government. I don't see any private hospital going into a loss to treat any disease. It's not by the benevolence of the baker that you get your bread. So if at all, I completely take the sentiment that, patients shouldn't have to pay more than a certain amount, particularly those belonging to indigent classes, but the government should step in and pay the deficit. I don't think hospitals should go into losses for this.
Okay, leaving it there, I think we're at an inflection point in India's response. 2-3 conclusions. There is some hope that remdesivir works if you catch and give it early enough. I think that's what I've picked up from all of you. Not once you reach the ventilator stage, but before the oxygen stage, for about 5 days, less than 10 days. Hydroxychloroquine continues to show some good results as a prophylactic. A vaccine is still some months away. Our contagion is still high. Our fatalities remain somewhat contained, mercifully, compared to the rest of the world. And it probably is time now for us to start unlocking, because otherwise the humanitarian crisis could prove to be much more egregious than the medical crisis. It's been a pleasure talking to all 3 of you, Dr. Trehan, Mr. Hari Bhartia, Dr. Ambarish, Satwik. Thank you so much for the special collaboration between Roli Pulse and MoJo Story. Pleasure. Thank you.